Here's what's in your scope, but ask questions. You see something that's like, I don't understand that. Ask questions. If the nurse can't explain it, call me. I'll explain it if I can. Right? Nurses aren't going to have all the questions, all the answers to your questions. EMS is different than nursing, and nursing is different than EMS. They can't do it without you. Believe me. Be busy. Stay working. Shouldn't be telling war stories in the hallway. Shouldn't be saying, hey, you won't believe what I just saw. You should be on to your next patient, because that's the way EMS works. You can mentally record all your stories, do it after shift, whatever. But while you're there, it's time to work. MTC and CPR is your final shift. It'll be divided, and when I say divided, that means you need to listen to the radio. We have radios. Everybody has radios. Fire will tell you that you have a lot of radio traffic going on. It's very confusing. Learn how to listen to radios, because in your field you're going to have to listen to the radio. You're going to start keying in on certain things. If you hear cardiac arrest, if you hear stroke, if you hear sepsis, if you hear trauma, that's when you need to key in and say, hey, I'm going to take vitals. About 5 minutes, I need to start walking that way. Use your time wisely. And by the way, if you're late for cardiac arrest and they're already pumping on the patient, I'm not going to say don't get in line. Chances are you missed it. Chances are you missed it, because the first 2 minutes, 3 minutes, things are going to move fast, and they're going to have a line of nurses, because they like it just as much as we do. Some nurses will get out your way, but to be honest, you're gonna have to work a little bit to get up there, because it is sort of exciting. Be a team player. Most importantly, be supportive of the mission. I started out with the mission. What's our mission? Improve patient outcomes. All right? Make the main thing the main thing. Getting all the vitals is not the main thing. Getting your grocery list of things that you got to get checked off is not the main thing. It's a big thing. That's what you're there for. However, patient outcomes is number one. All right? I was addressed with a problem yesterday, and I'm going to make it clear today to everyone. If you run into this, please let me know personally. Right? We had a student that was at the hospital the other day, and they were asked to sit, we call sitting on, to sit with a psych patient. They were there for about 8 hours. Not your job. Not your job. Okay? If that patient becomes violent, what are you going to do about it? Right? And if that patient has already got their hands on you, yeah, don't sit on a patient. All right? If that happens, you're going to have my contact information. And if I'm not on campus, you contact me directly. You can't get a hold of me, get a hold of Mama Bear over here. All right? We'll get it taken care of. You're not a babysitter. They are patient sitters. That's what they are. We have people who are paid for that. All right? Call them medics. Everybody get your phones out. Go ahead and scan that. On the first screen that comes up, there'll be an add contact icon. That's my information. It'll give you every way there is to get in touch with me other than smoke signal. Add that to your contacts. Thanks. Try to keep it guessing. You know what they say, never let them know your next move. Never let them know your next move. Stay off the milk cartons. All right, everybody got it? Good.
I have a question.
Yes.
So when you arrive to huddle, you're given your assignment and you're also given the nurse's name or whoever.
You're gonna move with that group.
Okay.
I call them gaggles. You will move with this gaggle of nurses, and you'll go to your zone. If a specific nurse is not assigned to you, like Zone X is going to be a little more specific, because we normally only have one nurse that goes there, and maybe a medic as well. But like Zone 1, you have a lot of nurses. You're going to be rotating around. You need to talk to the charge nurse and say, hey, I'm zone today. I need to do all the stuff and things. Okay?
And when you're moving between X and zone 1, because you said you have to split the 6 hours, or split the 12 hours, do we tell our nurse, like, hey, I'm going to...
Absolutely.
And then who do you find in the other zone?
Whoever the other person answered to,
Yeah.
say, hey, I'm relieving them, and then that other person should go over and say, hey,
Okay.
I'm your student for the next 6 hours.
Okay.
Okay? Questions? I know we got some. Please say. Please. Where? Okay. Questions, come on.
When we're taking vitals for the nurses and all that, how are we charging for that?
You can let them know.
Just like giving them numbers?
Yeah, and if they say, well, I gotta check it again anyway, okay,
Yeah.
thank you. Smile and wave, okay? That's all we can do. Just be nice, be polite. Some of them are gonna be like, students. Some of them will be like, man, students. And some of them are like, all right? Just remember that these nurses are just people too. All right? Some of them are going to be pains in the behind. Some of them are going to be nice. Some of them are going to act like you're not there. It's nothing personal. But I'm going to say something that may hurt your feelings, it may not. You're just another student. Okay? You're another student to them. Your job is to stand out and not just be another student. By the end of the shift, they should say, wish we had you all the time. That's how you create those good relationships. Because they'll remember you from school. When they finally work their way up the triage and they see you coming in with patients, we got one guy, Wes, who's a phlebotomist, and he came through the EMS class, EMT now, he's going to A this week, and when he comes in, we're all like, Wes! And Norm walking the cheers. We love seeing him, he's great. And he's doing a fantastic job. He's in my opinion, absolute dime piece. Good. But as far as, I'm just trying to make you understand, like, a lot of these nurses are tired. And I don't mean like from this past week. I mean from like 35 years of doing this. They're just tired in life in general. Some of them are not nice. Just be nice back. Kill them with kindness. All right? I do want to talk about patient reports real quick. All right? I'm going to say now a whole lot of questions. So I want to share patient reports in 30 for 30. Something we do in the hospital. And it's something that we're pushing regionally. This is not a Grady thing. So you're going to start seeing this at other trauma centers. You're going to see this at other hospitals. Region 3, we're doing a good job with it. It will be statewide. And it's nothing new, but it's something it's a new tire that we put some tread on, right? Or it's an old tire that we put new tread on. Our EMS units are with patients for about 30 minutes on average. The time that we touch that patient's threshold to the time that we drop them off the stretcher, usually about 30 minutes. In that 30 minutes, what all are we learning from that patient? Learn the whole story. Yeah, that's the best way to put it. Vitals, the history, medications, retraining. We're learning everything about that patient. When we get to the hospital, it's important for us to share that whole story in a short, efficient manner. Meat and potatoes. Okay? We call it the MIST format. That's going to be your basic demographics that include, 84-year-old female. Your M is going to be mechanism of injury. Okay? Ground level fall. I is also going to be injuries and interventions. So on that I, you got, she's got a lack above her head, bleeding is controlled this time. Move on to S, could be symptoms. Does have, all her mental status. Not normally like this. She's about GCS 13, normally a 14, but she's 13 now. And then T is going to be your treatments. Put her in position of care, or position of comfort. Check her vitals, but we really haven't done anything else. Or we gave her an IV in the right arm, possible CT on the way. So when you're giving this report, just make sure it's short and sweet, all right? 30 seconds, so 30-second report for that 30-minute transfer. Make sense? When you're calling your report in on the phone, you do the same thing. Our call takers are taking about 150 calls a day, on average, between 125 and 150, and not all of them are EMS. Sometimes we're receiving them from the floor to activate certain kinds of emergencies. So their time is limited. Don't give them the 15-minute story on a 16-minute transfer. Does us no good. All right? There are a lot of things that happen after the phone call that you don't know about. You have to activate the team. We have to register that patient. We have to do charting on that patient. We have to do a radio report on that patient. Page out that patient. There are like 6 or 7 different things that we have to do on any kind of activation, whether it's neuro trauma, sepsis, whatever the situation is. All right? So make it short and sweet. Be concise. Give them the full story. Say, hey, you know, right side of gaze, got some drift. I think there's going to be a stroke alert. Then support that with your vitals, support that with a history, support that with mechanism of injury, and then say, you know, then leave it up to the call taker to level that call, whether it's going to be a ground level fall or whether it's going to be a stroke or whatever it's going to be. All right. All right. Yes.
Since you mentioned that, I don't know if we're going to be able to give a report when we're on. Are we? Maybe.
So we limit you guys from doing radio reports on the truck just
Okay.
because we need it to be condensed meat and potatoes, but y'all will be getting fed cider.
Cool. So.
But if
is there-
it's a sepsis patient, if it's a trauma alert, things like that, we'll let the crew do that 30 for 30. And then after you guys, you know, head back to the truck, that preceptor's gonna say, okay, if that was your report, if you were talking to the trauma team, you give me a report, what would you have said?
And my other question would be, because you mentioned it, is there a specific hookup type ID that you need for CT that we need to give a report?
No, large bore, you know, which means, well, on your scope, no.
Right. I mean, for our scope, no, but if we're having to report for a medic or something like that, is there?
Generally you want a patent IV in the right arm. Right arm. And that's a good thing that you can remind your medic of. If it's a stroke workup, right arm. There's a reason for that. To put it in the left arm, the way that exactly you don't get the image. Okay? So right is right. You can't get it in the right, no, go on the left. Questions? Still nervous? Don't be.
A little less, but-
It'll pass. It'll pass, okay? And I'll be a resource there for you. If I'm not, I'm going to try to make sure that we have a medic there, not a nurse, but a medic that can be a resource for you. This is still a program that we are building. Anything that you see we can do better, take it back to Kayla. All right? Let her relay that. Is that fair? All right, I appreciate your time. I look forward to seeing all of you. You're going to be part of our team now. It doesn't matter whether you work for a fire department, you work for AMR, flight, eventually whatever you're doing, part of our team. When you bring us our patient, we need that first step to be the right step. We need to know what's going on. Okay? Thanks.
Thank you. Oh, this one.